All right, welcome everyone. Since it's a couple minutes past 7:30, we will go ahead and get started. Before I hand it over to Dr. Caravella, I did want to go over a few housekeeping rules. At the bottom of your screen, if at any time you would like to chat with our panelists or chat with anyone else who's attending this evening, you're welcome to use the chat. It is open to all. And then if you do have a question, there is a Q&A box. We ask you to please put your question right into that Q&A box and it will be answered at the end of the lecture. With that said, I will hand it over to Dr. Caravella, who is Allied Physicians Group Chief Quality Officer and one of our great pediatricians. Thank you, Dr. Caravella.
Thank you, Margaret. Good evening. Just a little background stuff. Tonight's lecture will be the final lecture in Allied Physicians Group Continuing Medical Education Program for 2023. Our program for 2024 is currently in development and will begin next February. Okay, our topic this evening is HIV PrEP for adolescents and young adults. The onset of adolescence brings not only changes to one's body, but also new vulnerabilities, particularly in the areas of sexuality, marriage, and childbearing. National data shows adolescents continue to experience negative sexual and reproductive health outcomes, particularly sexually transmitted diseases and HIV. Too many young people face barriers to reproductive health information and care. Tonight's speaker is a champion in this area, Dr. Dina Romo. Dr. Romo is the medical director of New York Presbyterian School-Based Health Centers. This program provides comprehensive clinical services, including integrated primary medical, preventive, dental, and mental health care, and a diverse array of health education and health promotion services to all enrolled students in New York City, regardless of insurance type and with no copay or cost to the students' families. Dr. Romo is a board certified in both pediatrics and adolescent medicine. She received her medical degree from the Albert Einstein College of Medicine, then trained in pediatrics at Mount Sinai Medical Center in New York City, and completed her adolescent medicine fellowship at Columbia University Medical Center. Dr. Romo was also the CDC National Network of STD Prevention Center Fellow at Columbia. Dr. Romo's areas of focus include improving access to equitable primary medical care, including sexual reproductive health care, psychosocial support, and complex at-risk adolescents in an urban setting. Dr. Romo is currently an assistant professor of pediatrics in the section of adolescent medicine at Columbia University's Vagelos College of Physicians and Surgeons, and leads multiple healthcare provider teams across various school-based health centers in Upper Manhattan and the Bronx. Dr. Romo has presented and published numerous times related to her general academic interests in adolescent sexual and reproductive health, and is with pleasure that I introduce to you and welcome Dr. Dina Romo.
Thank you so much, Dr. Caravella. It's a pleasure being here. Thank you for inviting us. I have the distinct pleasure of introducing our wonderful fellows. These are our adolescent medicine fellows. We could not do this work without them. So here we have Anita Huang, Carolyn Katzman, and Virginia Byron. So I'm just going to tell you a little bit about each of them before we begin the presentation. And then we'll be facilitating some Q&A at the end of the presentation. So Anita Huang is a first-year adolescent medicine fellow at Columbia. She completed her pediatric residency training at Columbia as well. We're very lucky she stayed with us. She went to medical school at the University of Texas Health Science Center in Houston, where she first became interested in adolescent medicine. Dr. Carolyn Katzman is a second-year adolescent medicine fellow. She went to medical school at NYU School of Medicine and completed her internal medicine residency at NYU and Bellevue. Lucky for us, she loves the adolescents, and her research focuses on how adolescents learn and make decisions about contraception. And Dr. Virginia Byron is a third-year adolescent medicine fellow. She went to medical school at the Ben-Gurion University of the Negev Medical School for International Health and completed her pediatric residency at Tulane University in New Orleans. She's interested in community-based participatory research and will be pursuing global health work in Tanzania next year. So we have a talented bunch here today, and I'm going to pass it off to them to begin our presentation. Thank you. Can we And I'll also just mention that we have no disclosures, and we'll be using some generic and brand names interchangeably just for ease of conversation and identification of the medications that we'll be using. We have, again, no financial relationship tied to these formulations.
I'll start with our agenda. So first, we'll speak about the HIV epidemic among adolescents and young adults, specifically in the United States. Then we'll talk about safety and efficacy of PrEP for adolescents, who is eligible for PrEP, and then how to initiate PrEP and manage PrEP in the primary care setting. And then we'll end with discussion of some common challenges to PrEP initiation and management in adolescents specifically. And we'd like to frame this conversation or this presentation with a case that may resemble a patient that you've seen in clinic before. So Melanie is a 15-year-old female patient here with her mom for her annual physical exam and some school forms. She has a history of mild intermittent asthma, which is well controlled, and eczema. They need some med refills, but no other concerns today. Her menarche was at 12. Her menses are regular, monthly, some cramps, 3 pads on her heaviest day. So no menstrual concerns. Review of systems is negative. And then you ask mom to step out of the waiting room for your confidential conversation. So in your HEDS assessment or SHADES assessment, which is our strengths-based HEDS assessment, her strengths are that she's responsible and outgoing. She says she has a lot of friends. She's in 10th grade, doing really well in school, good at math. She lives with her mom, stepdad, and brother, no safety concerns at home. She plays volleyball and she likes to make TikTok dances with her friends in her spare time. No substance use. Her mood's been up and down, but mostly good. No suicidality or self-harm. And she's happy with her body, no dieting or trying to lose weight. And her sexuality and gender, she identifies as female, uses she, her pronouns. She's attracted to everyone, all genders. She's currently in a relationship with a male partner, and she is sexually active, both vaginal sex and oral sex. And she's not intending pregnancy anytime soon. And she uses condoms about 8 out of 10 times. She's trying to improve that. So then she discloses that she and her partner were both treated for chlamydia 3 months ago after she was screened. She went to her school-based health center for STI screening and tested positive, and her partner got expedited partner therapy, and she's been asymptomatic since then. And she is interested in hearing about contraceptive options and what else she can do to prevent not only pregnancy, but also infections. And she's interested in trying an OCP. So your plan for the day for this visit is STI screening, including a test for reinfection of chlamydia 3 months later, and pregnancy testing. She wants her flu and her COVID vaccines. You start her on a low-dose OCP and give her condoms. So is this a good time to talk about PrEP? And is this a patient who would be eligible for PrEP? So, pass it along to Anita.
Awesome. Thank you, Virginia. So hi, everyone. Again, I'm Anita. I'm the first-year adolescent fellow at Columbia. And I just wanted to kind of frame our conversation today by first talking about like the population that we're kind of here discussing today. So just to briefly go over some epidemiology first nationwide, and we can become more granular as we go. This is from data collected by the CDC in 2019. They're obviously always updating incidents with new rates of different STIs every year. But as of 2019, you can see here for the first 2 lines on this graph, overall incidence of newly documented HIV infections among young people aged 13 to 34. If you were to kind of imagine those 2 lines stacked on top of each other, still makes up a large proportion of all new diagnoses of HIV, at least over a quarter of new cases. Next slide, please. And this is from the same data year, so also collated data between 2015 and 2019 to assess trends in HIV diagnoses, like grouped by age. Overall, reassuringly, rates of new diagnoses among young people are either stable or overall downtrending. So you can see for patients aged 12 to 24, trends in new diagnoses have decreased over time, while HIV diagnoses among people aged 25 to 34 has remained overall stable. And I just wanted to share some data that's kind of hot off the press as of 2022 within New York City, where we're practicing at least. I had the privilege of attending an adolescent sexual health symposium this afternoon, and some representatives from the Department of Health were here to talk about PrEP and HIV cases in New York. As of 2022, 55 new cases of HIV were diagnosed among teens 13 to 19 years old. And overall, between the ages of 20 to 29 years old, 539 new cases were reported to the Department of Health. And I think in the context of the population at large within New York, it's obviously a very dense place. If you think about it, any new HIV diagnosis is very heavy and carries a lot of weight for individual folks. So it's still a pretty significant burden. Next slide, please. So hopefully you can see this slide. This is also from the CDC. They put together biannually this really amazing interactive tool called the Youth Risk Behavior Survey. Essentially, the CDC administers a set of surveys to students from 9th through 12th grade across the US, asking like really a ton of different questions overall to monitor trends in behavior and risk factors that can lead to unhealthy outcomes like contraction of STIs, challenges in mental health or suicidality, or childhood obesity. For those of you who have been on this tool before on the CDC's website, it's a really amazing, I think, visual tool to overall look at this data at many different levels, both like nationally and more granularly within states, territories, and tribes. So I'm happy to walk anyone through this tool at a later point if anyone's interested, but for your own interest, if you go to the CDC's website, you can actually toggle between different either behaviors or risk factors, and just see how that plots out nationally. I thought I would just include this slide to give you all a sense of what HIV screening looks like lately. This is published from 2021. Hopefully we'll have new data this year. But this map overall shows how testing rates have improved from 2005 to 2021. It's a little bit kind of backwards to interpret, but the darker purple states here indicate states that have higher rates of youth who have never been screened before. And if you think about current guidelines for HIV screening, we know, at least for like the sake of pediatricians, patients should be screened for HIV at least one time in their lives between the ages of 13 to 64. So this is like definitely falling within our purview as pediatricians, as just part of routine healthcare maintenance. The lighter purple states indicate higher overall lifetime rates of HIV screening. So New York has seen higher rates of screening. Unfortunately, some states didn't collect as much data as indicated in white, but I think this was really interesting for me to see, at least. Next slide, please. So let's talk about risk factors a little bit. Overall, behavioral risks have decreased among sexually active youth. And we know that fewer high school students are actually sexually active, but there's definitely still behaviors that students are engaging in that can place them at higher risks of contracting STIs, including HIV. Alarmingly, condom use is down to 52% in 2021 from 60% in 2011 among sexually active students. We also know that substance use is on the rise, not just with what we hear about a lot of the time, including like vaping and cigarette smoking, but also marijuana use, alcohol use. This in social situations we know impairs judgment for youth, which can also lead to higher risk behavior. And of course, sexual violence is certainly a risk factor for youth. And this becomes particularly salient for queer youth in our community who face higher rates of sexual violence. So why does all of this matter? Nearly half of newly diagnosed youth who are HIV positive are not aware of their infection status. So it's important for us as providers to think about screening and provide education for youth who are screened to live healthy lives thereafter. We know, I think, as a whole, that young people are in dire need of improved sexual health education, not only in school, but in conversations with their parents and providers or caregivers overall. Young people need to know how HIV is transmitted. I think there's a lot of misinformation that is spread about HIV transmission. We know from the last slide and from national data that healthcare providers need to improve screening rates among patients aged 13 and up. And healthcare providers need to be comfortable with discussing PrEP with all youth, not just eligible youth. And we'll go into more detail about this later in our presentation. We also know that risk-based screening tools or previous algorithms to sort of help care providers decide when to talk about PrEP can actually stigmatize patients. Just because patients in a clinical setting do not disclose sexually risky behaviors doesn't mean they're actually engaging in them for many reasons. They might not be comfortable talking about their sex lives in a clinical setting. So just normalizing this conversation around sexual health overall, but also PrEP, helps to destigmatize these patients and make this conversation overall more comfortable for everybody. Next slide, please. To kind of hammer this point home, it's really important overall to destigmatize frank conversations about sexual health. And I want everyone to kind of internally reflect for just a moment about how you discuss sexual health with your patients. I think in general, we, within our adolescent practice, try to include many different aspects of sexuality in this conversation, including gender identity, chosen pronouns, body image concerns, relationships, peer pressure. All of this is really important to include in this conversation to, again, normalize this chat. I think something that providers also need to become more comfortable with is talking about explicit sexual health practices, including receptive sexual practice, oral or anal sexual practices. These, of course, can inform triple site testing for things like gonorrhea and chlamydia that, as we know, can be transmitted orally or rectally, but also for HIV as well. And some things that I think we can include as part of our conversation with patients is to have patients just consider their own risks, have patients reflect, you know, have I had sex either anally or vaginally with a person who is HIV unknown? Have I ever been coerced into having sex with someone whose status I don't know of? Have you ever recently or in the past been diagnosed or treated for an STI? These are all really important questions to consider. Overall behaviors that increase the risk of contracting HIV in particular include receptive anal sex, or bottoming, as most people I think are aware of the term. Receptive anal sex carries higher risk than vaginal and oral sex, just because the mucosa within the rectum is very thin and is very susceptible to microtrauma during sexual activity. It's been well studied that HIV negative individuals who engage in receptive anal sex are at much higher risk of contracting HIV. In general, contracting HIV from oral sex is exceedingly rare. And I just want to use this moment to also touch on barriers that a lot of our patients in our community here in New York, but I think nationwide, face in receiving sexual health care, but also prescriptions for PrEP as a whole, include access to different factors that allow patients to get care. Some patients might have issues with transportation to different clinics. The cost of healthcare and medications can be can preclude patients seeking care. We know that housing instability is also a major risk factor. Mental health concerns is also huge, especially in these last post-pandemic years, as we know mental health has deteriorated for a lot of our teens overall. And that can definitely affect access to care. A lot of teens, I think, have concerns about confidentiality in seeking out sexual health care and asking for prescriptions for PrEP. And we'll touch on this in a little bit, but that's something to also keep in mind during your conversations. And I think the bottom line of this presentation and what we're kind of hoping you step away from this talk with today is a sense of increased comfort in just at least talking about PrEP as part of your anticipatory guidance. Clinician comfort is a huge barrier to young people receiving frank conversations about PrEP and PrEP prescriptions as a whole. So hopefully we can help with a little bit of that today. Next slide, please. Okay, perfect. To just touch on consent, and this, I think, leads into concerns about confidentiality. I know that some physicians in this group are kind of all over and practice outside of New York as well, but for the New York State as a whole, in 2017, the Department of Health actually expanded provisions for minors less than 18 years old to consent for HIV prevention and treatment, including screening for HIV and PrEP or PEP prescriptions. And this very nicely also blanket applies to treatment and preventions of other STDs in general. This means practically that care can be provided without the involvement of parents or guardians. I say this with the caveat that, we know that buy-in or caregiver involvement might help with adherence, especially among this population, and overall might just improve frank conversations around sexual health outside of like our clinical bubble. But we should keep in mind that this autonomy should be allocated to each patient's individual case. And just to, again, sorry, Virginia, one slide back, to touch on consent and confidentiality. One thing that I always kind of forget about when patients ask me if their parents will be notified that they're receiving any sort of care. I think it's important to remember that patients can request that explanations of benefits can be sent to an alternate address. So if you and your practice are prescribing PrEP and your patient is concerned that they'll get a letter in the mail saying that they received a prescription from you, you can help your patient either in your visit or immediately after contact their individual health insurance plans and have that address changed. This isn't as much of a concern for patients enrolled in Medicaid, because Medicaid doesn't usually send EOBs home, but other commercial insurances may. So you or ancillary staff in your clinical practices can help reach out to insurance companies to alleviate that stress. Next slide, please. Thanks, Virginia. So what is PrEP anyways? This is kind of a primer to the meat and potatoes of our talk. But PrEP stands for pre-exposure prophylaxis, that greatly reduces the risk of contracting HIV among HIV negative persons. We'll talk more explicitly about formulations available to us, but formulations include pills, including Truvada and Descovy. We know that with pill formulations of PrEP, maximum protection is achieved by 7 days of consistent use for those engaging in receptive anal sex, and by 3 weeks of consistent use for those engaging in penetrative vaginal sex. The new kid on the block, so to speak, is Apretude or cabotegravir, Cab-LA. We'll talk a little bit more about this agent in a little bit, but it's very useful in patients who need some flexibility in their PrEP dosing. And we know that up to 99%, PrEP is up to 99% effective in preventing HIV contraction through sex when taken as prescribed. We know this in at least clinical data collected from adult studies. This is a little bit harder to predict among people who use or inject IV drugs, but it's estimated to be about 70% effective in preventing HIV contraction. Next slide, please. So this table just kind of details what I briefly touched on, and Caroline will go into more detail about these different formulations and flexibility in administration and prescribing. But important to know that Truvada, which is the, I believe, only formulation that's available as a generic and brand name, is available as a daily form of PrEP or on demand, which we'll talk about in a little bit what that means. Truvada is approved for all people, including people who inject drugs, but on demand use is only really well studied among men who have sex with men. Descovy is I believe brand name only formulation of PrEP that's approved for men who have sex with men and transgender women with increased sexual risk. And Apretude, our injectable form of PrEP, can be injected every other month and is approved for everyone over the age of 18. So a really exciting prospect. I'll pass it over. Oh, wait, sorry. One more slide on PrEP coverage. Just to talk a little bit about access. Important to know that the ACA has mandated that nearly all health insurance plans cover PrEP, including Medicaid and Medicare. For patients who don't have insurance, there are a lot of really wonderful resources out there that vary by community. Ready Set PrEP is a fantastic program that provides free PrEP to qualifying individuals who meet criteria for not having insurance and making a certain percent of the federal poverty level. But there are many statewide community-based programs that offer either sliding scale or co-payment assistance in getting PrEP and undergoing surveillance care that's required of PrEP. And I believe that's all I have. I'll pass it off to Caroline.
Hi, everyone. I am Caroline. I'm the second year adolescent medicine fellow at Columbia. So I'm going to talk a little bit more about the nuts and bolts, who is eligible for PrEP and how we actually prescribe it in the primary care setting. So this is from the CDC in 2021. It's the summary of clinical guidance for daily oral PrEP use. And these are folks who are eligible and should be discussed recommended PrEP. So for all sexually active adults and adolescents, anyone who's had anal or vaginal sex in the past 6 months, and any of the following. So has a partner who has HIV, has had a bacterial STI in the past 6 months, or has a history of inconsistent or no condom use with sexual partners. And we'll talk a bit more about this in a second. For patients who inject drugs, it's especially recommended for those who have an injecting partner who has HIV or who share injection equipment. And then in order to prescribe it safely, all of the following conditions need to be met. So the patients all need to have a documented negative HIV test, should be an antigen antibody test within a week of the initial prescription. No signs or symptoms of acute HIV, an estimated creatinine clearance of greater than 30, and no contraindicated medications. And we'll go quite a bit more in depth about these as well. So this is the HEADS assessment or the SHADES assessment, our bread and butter of adolescent medicine. And it's, a really crucial part of our history gathering, both to get to know our patients, get to know more about them, and to understand risk factors for disease or issues in school or trauma or abuse, and to discuss how best we can help our patients. This should be done confidentially, one-on-one without a parent in the room. And patients we should discuss with them the limits of that confidentiality. So the limits include a patient who is thinking about hurting themselves or killing themselves, hurting or killing somebody else, or if somebody has been hurting them. Those are times where we'll need to talk to a parent. Otherwise, everything we talk about is confidential and private. And this is a really crucial part of our history gathering. I think it's important to note that we both will take a thorough sexual history while we're doing this, but we'll also identify psychosocial factors and barriers to taking medication every day, which could be really, really important for a patient who would like to be on PrEP. So these are the 5 P's of a sexual history: partners, practices, pregnancy, past history of STIs. I always thought that one was a little bit of a stretch. And then protection from STIs. And so really being thoughtful about how we ask young people these questions in order to, we're not trying to be nosy, we're trying to understand their risks, right? And how we can best help them as physicians. So partners, have you had sex in the past 3 months? How many sexual partners do you currently have can sometimes be a tricky question and not so relevant, can make folks feel uncomfortable. I usually will say, do you have one partner or several partners, just to kind of better understand their risk. We, now like to ask the question, what are the genders of the people that you're having sex with? I know we traditionally have asked, do you have sex with men, women, or both, but that can be very exclusionary. And so really asking, what are the genders of the folks that you're having sex with? And then importantly, do your partners have sex with other people? I think is a question that often doesn't get asked. And there's, usually, often people can know that their partner's having sex with other people and be very comfortable with it, but it won't come up unless you ask. Practices. So what kind of sex are you having and what body parts are involved? Really being mindful to use and mirror the language that your patients are using. They may use different language for their body parts than we learn in medical school or that you're taught, but really making sure that they know that this is a safe space and that they can be comfortable talking to you about these things. Asking a very broad, open-ended question, what kind of sex are you having? I think also can be useful to understand really what they're doing and in what ways they might be at risk. Assessing for pregnancy, and really, I think the most important question here is, if somebody does not wish to be pregnant, what are you doing to avoid pregnancy? Not asking specifically about birth control, because that can be pretty narrow. Sometimes folks will do a lot of things to prevent pregnancy that they don't really consider to be birth control. has history of STIs, relatively self-explanatory, and protection from STIs. So asking about barrier methods, both condoms and internal condoms, right? And then I usually ask, like, out of 10 times, how many times would you say you use a condom, right? Really having it more of like a strengths-based approach, not how many times do you not use a condom, right? And then also having them quantify it, I think, can help give a more accurate picture. So this is a super useful algorithm for the CDC. So we're going to take a few minutes going through it. But these are the folks who they think are at significantly increased risk of contracting HIV and who really should be offered and encouraged PrEP if it's something that they want. So the question that I don't like, sex with men, women, or both, we can ignore that. I would ask, what are the genders of the folks that you're having sex with? But then, so anyone who's had anal or vaginal sex in the past 6 months, and kind of divided into 3 buckets. So there's somebody who has a known HIV positive partner. And for those folks, specifically if the partner has an unknown or detectable viral load. We know from the U equals U, undetectable equals untransmittable campaign that folks with a undetectable viral load have no risk of transmission of HIV. That being said, difficulty taking medication can happen, missed pills can happen. And so all of these patients should be offered PrEP if it's something that they're interested in, but especially if their partner has an unknown or detectable viral load. Our next bucket is folks who have had 1 or more sexual partners of unknown HIV status and don't always use condoms. So I feel, a lot of my patients fall in this bucket, right? And, often kids who we don't traditionally think of as being good candidates for PrEP really are eligible, and it really should be considered, right? Kids who have sex partners who haven't been tested and are not using condoms, really this should be discussed and encouraged. And then the last bucket, like our case patient, anyone who's had a bacterial STI in the past 6 months. So for men who have sex with men, those STIs could be gonorrhea, chlamydia, or syphilis. And for men who have sex with women and women who have sex with men, it could be gonorrhea or syphilis, not chlamydia. Those are folks who really should be encouraged to start PrEP if it's something that they like and that they're comfortable with. For me, the key part of this slide is that all arrows lead to discuss PrEP and prescribe if requested, right? So we should, anyone, even those who have not had anal or vaginal sex in the past 6 months, we should be discussing PrEP with them. And anybody who requests PrEP, as long as there's no contraindication or safety issue, even if they don't meet like your clear CDC criteria in your mind, those are kids who should be offered PrEP. Much more straightforward. These are for folks who have injected drugs. So specifically folks who have injected drugs in the past 6 months who share injection equipment. Really, it should be recommended. The medical recommendation would be to start PrEP, but for any patients, again, should be prescribed if requested. So what labs do we need to get to start PrEP? So the 2 that are italicized, HIV and creatinine, are really the 2 that we need to like same day start. Like we need the results for those to start. Everything should be sent, right? But we can go ahead and start PrEP without the other results. Okay, so HIV testing, really important because PrEP is a partial HIV treatment. And so if folks who have HIV are receiving PrEP, they can be at increased risk of developing a resistant virus. So we must document a negative HIV test within a week of initiation. Ideally, it should be an antigen antibody test. It cannot be patient reported. It's discouraged to use a saliva rapid test just because those are less sensitive for acute infection. If a patient has had a known exposure in the past month and has any signs or symptoms of acute HIV, so viral symptoms, fatigue, myalgia, fevers, lymphadenopathy, rashes, it's recommended to send a quant HIV viral load. If that's negative and there are no symptoms, we can start PrEP. If it's negative, but they continue to have symptoms, it's recommended to actually wait 2 to 4 weeks and repeat the test. A BMP for renal function, so specifically checking the creatinine, there have been shown to be some small decreases in renal function with PrEP in certain patients. These changes all reverse with discontinuation. The reason we check is it's more likely to have an impact for those with a creatinine clearance less than 90 or who are over the age of 50. For young people who have any renal dysfunction, you just want to monitor very closely. And then importantly, Hep B infection, so tenofovir and emtricitabine are both treatments for Hep B. And so what you worry about is a flare of hepatitis B when the medication is discontinued. So if folks are found to have Hep B, it doesn't mean that they can't take PrEP, but it does mean that you should really monitor closely if discontinuing, and consider a GI liver eval. And then a lipid, Hep C, we check. Well, it's not on here, but we also should check a pregnancy test for anybody who can be pregnant. And then a lipid panel, specifically because Descovy can cause some metabolic changes, elevated triglycerides, and weight gain. So Anita did a wonderful job going through this, but just briefly, Truvada is approved for all healthy adolescents and adults at risk of HIV. There is a generic, so it's more easily covered by insurance, and it's a lower cost option. It's the most commonly prescribed. The main side effects are headaches, abdominal pain, weight loss. They almost always go away after the first month. And then Descovy is only approved for men who have sex with men and transgender women at sexual risk, at increased sexual risk. It's specifically not approved for women who are at risk through receptive vaginal sex, and there's no generic for this medication. It can be used for those with some renal dysfunction and a lower creatinine clearance of greater than, as long as it's greater than 30, it's safe. And this is more likely to cause weight gain and lipid abnormalities. The one thing that I do want to mention here is there's been some work that looks at bone health of young people and adolescents on these medications. So they measure bone mineral density at the starting point and a year later with Truvada, and they did show some decreased bone mineral density. In the older kids, ages 18 to 22, this reversed with discontinuation of the Truvada. But in the younger kids, 15 to 18, these changes did not reverse. I think it's important to note that the changes were small, and we do not know if they were clinically significant. And as long as a kid is healthy and has no other risk factors for decreased bone mineral density, it really shouldn't be that much of an issue. If Descovy is covered, which doesn't have these same effects, that might be a good medication for them. But if Truvada is the only medication that's covered by their insurance, it's a generic, their risk of acquiring HIV could certainly be more substantial than the decreased bone mineral density, and it's worth talking about. We're running a little short on time. There are just very few drug interactions. I'm not going to spend a ton of time on, but I just want to get to this slide about how we screen. So we talked about the initiation tests. We need an HIV test every 3 months. So this is like the really big one to keep in mind. So usually we would do a 90-day prescription and make sure not provide a refill of that prescription without checking an HIV test, because you really do worry about the resistance. Renal function, you really only need to check every year as long as they are otherwise healthy with normal renal function and under the age of 50. Otherwise, it's every 6 months. STI testing, the CDC recommends for the men who have sex with men and transgender women at increased sexual risk every 3 months, or every 6 months for everybody else. And Hep C for those who are at increased risk every year. And for those on Descovy, I'm sorry, a lipid panel every year as well, because that does cause some lipid abnormalities. Always important to ask follow-up questions, so checking in on their sexual history, any changes, barrier methods, the importance of condom use, any side effects or safety concerns, and then importantly, adherence, which is, I think, a really key point of PrEP, especially when you're working with adolescents. So studies have shown that the risk reduction, HIV risk reduction with 7 doses per week is 99%, which is extraordinary. For those who only take 2 doses per week, it's a 76% risk reduction, which is still good, right? But a significant drop off from the 99%. And then a study that looks specifically at adolescent boys ages 15 to 17 on PrEP showed that half of them had protective levels when checked every month with monthly visits. But when switched from monthly visits to quarterly visits, it dropped significantly. So difficulties with adherence, we know, can be a big problem with adolescents, often a reflection of biological behavioral transitions during this developmental time. More autonomy, more influence of peers and stigma, and an undeveloped cognitive capacity for planning. And we're going to talk a bit more about how to combat some of these in a minute. All right. Apretude is a very exciting injectable PrEP. We're not going to spend a lot of time on this because it's only FDA approved for those over 18, but it may be appropriate for those who have difficulty taking a pill, who have significant renal disease, or who just would prefer an injection. And it's shown to be very safe in adults, the only real monitoring of HIV tests. And then 2-1-1 dosing, just mentioning this because this comes up a lot with PrEP, and it's just worth going over. This is also called like on-demand PrEP. It's only been shown to be effective in men who have sex with men, and it's designed to meet the needs of men who just have sex less frequently and don't want to take a daily pill. It's also only been shown to work with Truvada. Notably, it might be hard for adolescents to keep track of a difficult dosing pattern. And also, the first dose needs to be taken 2 to 24 hours before sex, and adolescents sometimes have difficulty planning that. When you take the first dose 2 to 24 hours before sex, then 24 hours later, and then another 24 hours after that. Okay.
Thank you, Caroline. To get back to our case, back to Melanie. She's 15. She's in your office. She's a long-time patient of yours, and she's here for her well check. So to recap her sexual history, she is sexually active with male partners. She's motivated to start an OCP today to protect against pregnancy. And she has had a recent bacterial STI, although it was chlamydia, which puts her at slightly lower risk for contracting HIV. So you can ask her, would you like to hear about PrEP today? And give her a little bit of background on what it is. Once you talk to her about it, she says, yeah, I'm motivated to start. I want to protect myself against pregnancy. And why wouldn't I also want to protect myself against HIV? So she falls in that, in the recommended category on the flow chart from the CDC because she has inconsistent condom use, which a lot of our patients kind of would qualify based on that criteria. So the labs that you send today, you're already planning to do STI screening. So making sure that you're including the HIV in addition to gonorrhea, chlamydia, and RPR, sending a BMP to check her creatinine, and then also Hep B, Hep C, and the lipid panel. Once the HIV test comes back negative and her creatinine comes back and it's normal, you send in a prescription for Truvada, the 200, 300 milligram, that's the standard dose, daily for 3-month prescription. And you tell her that she'll be due for a refill in 3 months, that she needs to come back in for HIV retesting before you're able to refill it. So how do we, as Melanie's PCP, set her up for success? So patient factors. You can ask her directly, how would you feel about involving your parents? because I find that actually a lot of my patients, or maybe not a lot, some of my patients are just embarrassed to have that conversation with their parent. So if you offer to mediate that conversation with them, you can frame it in terms of her really taking active steps to control her health, that this is a very mature decision that she's making. And then when you have parents on board, that can make a lot of other things much easier, including confidentiality. They can help with adherence. But of course, for many of our patients, they definitely do not want the parent involved, and that's completely fine. And there also may be safety concerns, especially for patients who identify as, who may have transgender gender identity or sexual minorities. So confidentiality concerns. Confirming that her patient portal is set up correctly, if that's something that you're using in your practice, and considering, even encouraging her to consider a different pharmacy if her pharmacy sends automated prescription reminders to her parent. Preparing her for potential side effects. So in the first month, you may have mild GI side effects, some diarrhea. These are transient, and if any of them, any of them are affecting your functioning, or you're really struggling with them, definitely come back in and we'll talk about it. And then tapping into those motivational interviewing techniques. So identifying what her motivators are to be taking this, what things are going to help her remember to take it, and then what her barriers might be, and kind of walking through, like, from the moment that you send the prescription in, how is she going to get to the pharmacy? How is she going to pick it up? Is there a copay? How are you going to get back to appointments? And walking through some of those steps. Like Caroline mentioned, adherence has been shown to be better in teenagers with frequent visits. So consider, especially when first starting, consider follow-ups every month. And then how can she remember to take it every day? So there are apps to help with this. I'll show an example of one in the next slide. She can designate a trusted adult or a friend to help her stay accountable, or her partner, maybe they're on it together. She can pair it with another habit. So if she's already been on OCPs and she's doing a great job taking those every day, she can kind of try to tack this new habit onto that one, setting alarms, all of those. This is an example of an app to promote adherence for PrEP. It's called PrEP. It allows patients to track their PrEP usage, their sexual activity, their doctor's appointments. You can say which way you can designate in the app which way you take PrEP, and then you can swipe every day when you've taken it, and it keeps track of how you're doing with adherence. And then setting our patients up for success on the systems level. So if you have the resources in your clinic, and to advocate for a PrEP navigator position to help patients with everything from insurance issues and pharmacy issues to transportation, and some of the social determinants of health that may be affecting adherence. Confirming your confidentiality procedures at your clinic, at the clinic level, with the electronic health system, with the insurance providers, like we mentioned earlier. And you probably already know from your experience that most Medicaid plans don't send EOBs to families, but commercial insurances, a lot of them will, which can be a barrier for confidentiality for our teenagers. And then also on the pharmacy level as well, maybe partnering with a local pharmacy who will be good about not sending reminders to parents for PrEP prescriptions, setting your clinic up in a youth-friendly way, combating HIV stigma, so using the opportunity during the HEADS assessment or during the shades to talk about U equals U, undetectable equals untransmissible, and what it means to have HIV in 2023. And then, of course, holistic care for our teenagers. So screening for and addressing mental health concerns, safety concerns, and social determinants. And you've already, with this patient, kind of made the biggest first step, which is developing rapport. They've trusted you, you're their pediatrician, and she's disclosed a lot to you. And so clearly there's trust there, and that's the most important starting point. So Yeah, right on time. We're happy to answer any questions. We love talking about how to take care of teenagers. Thank you so much for having us.
Thanks, everyone. And thank you, Anita, Carolyn, and Virginia. So we do have a couple of questions in the Q&A, so I do want to take a chance to take a look at them. And, you know, the question about explanation of benefits and how to maneuver this, because as you may have all experienced, whether in dealing with contraception or other confidential services, it can be really tricky to deal with explanation of benefits. You know, as mentioned in the talk, with Medicaid, it's much more straightforward. Explanation of benefits are not sent home. With commercial insurance, it really depends on the insurance. And my experience has been that calling the insurance is really the best way. Changing the address may or may not work. You have to kind of know your patient, know your families. The dynamic is going to be different everywhere, and really have a frank conversation with your adolescent, because in the room we can really promise them the moon and stars about confidentiality, but we really have to consider kind of what happens on the back end of things. So really the key is, you know, calling the insurance company, and that can be really tough when you're doing this, you know, live with a patient in front of you, and trying to get them started on PrEP same day. So you really have to plan it out to give yourself a chance, or give the patient a chance to call the insurance, figure out how this can be maneuvered. This is really, my experience is, this is really where a PrEP navigator, and you know, whether it's the title is specifically for a PrEP navigator, I feel like that exists mostly, you know, in bigger centers, but having a patient navigator or your practice administrators that may be a little bit more savvy in this, and really calling the insurance and finding the nuances to preventing the explanation of benefits, because, you know, it's not clear cut. So I do hear that it is quite tricky. There's another, I don't know if the fellows have anything else to add regarding explanation of benefits.
Yeah, I don't have any magical solution. I think it's a huge barrier. I would say if a patient's really motivated to start PrEP, and confidentiality is a primary concern of theirs, then also knowing the resources in the area, whether or not there's a school-based health center that stocks PrEP, or some kind of free STI clinic that might have it, or if they qualify perhaps for the Ready Set PrEP as well, and having those resources kind of in your back pocket.
Yeah, it really is a systems issue. I mean, in our centers, we either keep it in stock at our school-based centers, we keep it in stock, and then we work with our patient navigators to make sure that when school-based health is a lot easier, because, you know, we provide care regardless of insurance, and we don't send any bills home or explanation of benefits home, even if we're dealing with commercial insurance, we're just not charging insurance, but that's a totally different system. So, you know, if you're really stuck between a rock and a hard place, and there's no way of getting around and addressing the EOB issue, as Virginia said, is just finding other resources in the area to provide the service. Moving on.
Oh, I just wanted to address also the second part of Janice's other question. In terms of the on the clinic level, the way that our patient portal is set up is that between the ages of 12 and 18, our patients have their own accounts, and then parents have proxy access to their accounts, which allows them to see upcoming visits and non-confidential medications and non-confidential labs, and we can designate some labs and medications especially having to do with sexual and reproductive health, default to being confidential from the parent. So only the teenager with their own account can see it. And others you can designate as confidential or not. So that's the way we have it set up. But again, it's definitely a systems level issue. And if absolutely, if the parents can see everything in the patient's account, then that definitely is a big barrier to care.
Yeah, absolutely. The patient portal is going to be key, and it's, you know, finding back end ways to ensure confidentiality is going to be really important. Moving on, there's another question about the epidemiology and the incidence of HIV in females under 24. Anita, I don't know if you have any more granular data, but I can surely just generally say it's very low in HIV females, HIV adolescent females. It's really quite low. Just females in general, the rate is low compared to men who have sex with men, and that rate is around 6% nationally. And so adolescent females fall much, in this much more, even less, around like less than 2% even was the last number that I saw. But Anita, I don't know if you have any more recent data or more granular data.
Yeah, I'm sorry. On the epidemiology slides I included, they didn't really stratify between sex. It was just by age. So apologies for that, but I can definitely find more information on that and send that out.
Yeah, and the numbers that I just quoted are from like 2018, and I couldn't find something more recent, but as Anita mentioned, overall the numbers are stable. That said, while the numbers are, very low, it's still worthwhile having these conversations, and it's really more of a shared decision-making process with the adolescent. And essentially now, the conversation and what the CDC recommends, it's while it's a risk-benefit conversation that you're having with the adolescents, I kind of see it similar to, a patient that's coming in requesting for STI testing or Plan B, and in really assessing their risk, it doesn't feel like, they need it as much. But the key with adolescents is that you just never know, in terms of what they're truly disclosing to you or not, what they're feeling comfortable, about disclosing or not. I've definitely been in many, thankfully it's not the common thing, but we've definitely been there where, patients don't report sexual activity or it seems very benign and they're following all the preventive behaviors that you're recommending. And then, they come back positive with HIV or positive with another STI. So it's, we really just have to, if they're insisting on PrEP, we shouldn't ignore them or discourage them from it. We should have a conversation about it. And come to a shared decision-making process and helping them understand the risks and side effects of starting this medication that doesn't go without some side effects. And thankfully, for most healthy teens, those side effects are not significant where it's making a big difference in their health, and most of them are reversible. But it is not without risk. Other questions? So nearly all of our Medicaid is managed Medicaid. Do they send EOBs? They do not. Under what circumstance would we prescribe Descovy over?
I could take this one.
Truvada for MSM. Go ahead.
Yeah, so in adolescents, almost always you're going to be prescribing Truvada over Descovy. There are really two different circumstances where Descovy would actually be preferred. One is young people with impaired renal function, right? Because Descovy is approved for creatinine clearance greater than 30, where Truvada is a creatinine clearance greater than 60. Again, I would say this is probably a very minuscule proportion of the adolescents, young adults that we're taking care of. And then the other impact is Descovy is shown to not have an impact on bone mineral density. I will say that I feel like this is only really relevant if a patient has other risk factors, such as an eating disorder or chronic steroid use or something that would make you already worried about it. CF, yeah. exactly. So otherwise, I think that like, even if there is a small decrease in bone mineral density, we don't know necessarily that that's clinically significant, and Truvada has a generic, right? So I think for most people, Truvada will be the choice. There's just very few circumstances where Descovy would be preferred. In adults who have chronic medical issues, renal dysfunction, if they're older in age and have osteopenia, osteoporosis, Descovy is going to be more of a good fit for them. But in young people, Truvada is usually going to be your choice.
Great. And I'll add that, you know, in adolescents, because this is the key time where they're laying their bone mineral density. You know, it is something to consider, but at the same time, the impact that it has on bone mineral density versus the risk of acquiring HIV in somebody who's at risk is also something to consider. Also, in terms of its impact on bone mineral density, it's greatest in the first couple of months of starting PrEP, and then after that, that bone mineral density, its effect on bone mineral density really stabilizes out. So it's not something that, you know, continues to compound over time. So that's also reassuring. It does reverse once somebody stops taking PrEP. But something to note is that in those adults who stop taking PrEP, the reversibility is better in terms of bone mineral density compared to adolescents who they might not, you know, completely reach their full bone mineral density potential. You know, once they discontinue that. So again, at the end of the day, what you're really looking at is, in terms of choice, is whether you already have existing risk factors for having a low mineral density or even the renal risk or of dysfunction.
Dina, correct me if I'm wrong. Maybe we just don't have this data yet, but I don't know. I don't think that decreased density within this population has necessarily plotted out to like clinically significant outcomes like increased fractures or osteoporosis. I mean, I'm sure that would take a lot more longitudinal data, but it's just not something we've seen.
Right. Yeah. Yeah. And I think that, you know, there's ongoing studies, of course, to better understand Descovy. The most data and the reason why we feel most comfortable with Truvada in adolescents is because that's what we have the most data for. Okay. The next question, are you universally HIV screening all of your adolescent patients with an opt-out strategy, or only if risks are identified or requested? And how do you approach the patient who refuses testing even when risks are identified? So that's a great question. And really, I follow, and I want to say, you know, and Anita and Carolyn and Virginia can chime in, but my practice is to follow the CDC guidelines. So I really just normalize taking a sexual history and present and normalizing doing an HIV test. And even somebody who's not sexually active, I'm still recommending an HIV test. And I just simply say, this is what the CDC recommends. And, you know, they have data to support that it's a good practice to have an initial HIV test just to know your status. It sounds like you're not at risk. So it's more just like any other routine lab test that we're doing. And again, the reason why it's not so much that I'm pushing back on their honesty with me about their sexual activity, right? But it's always like, just again, normalizing the testing, and that approach just essentially captures somebody who may be at risk and is just not ready to disclose that. And then how do I approach a patient who refuses testing even when risks are identified? I kind of roll with resistance. So that's kind of like, you know, the theme of taking care of adolescents. You really have to ask why. And this is sort of like where, you know, whether it's motivational interviewing or just common sense conversation, it's like, well, you know, tell me why. And sometimes your answers are very simple, such as like, I don't want a needle. Like that tends to be the main answer, at least in our school-based health setting. It's like we're not doing other routine labs for them, often in school-based health setting. And if we are, I usually can normalize and say, well, you know, this is just another test that we're going to be at, is no extra needle. But when it's just the HIV test and that needle for a blood draw, that tends to be what makes them shy away. And the other times it's because they're either scared, they really don't understand HIV. They've heard, you know, horror stories about it. So it's really just trying to figure out where the no is coming from. And that's my approach. Anita, Carolyn, and Virginia, I don't know if anything else you want to chime in to that question.
I have nothing to add, Dina. I agree with you.
Okay. Do you do virtual visits for prescription refills? Are we able to refer to you to ensure patients can get confidential care without the parents being notified? I'm going to say yes to all of that. So in my previous practice, when I was not doing school-based health, I did do virtual visits for prescription refills for PrEP. So you really, again, have to work with your systems and the systems you have in place for your clinic. You know, having the conversation is easy, right? Because you really need to assess their risk, their adherence, which is mostly conversation, right? There is no, we're not testing levels of the medication. But you do want to eventually, but you still do need to have your intermittent testing for either HIV or, you know, their other STI tests, pregnancy tests. And by the way, also always, I wanted to add just pregnancy tests in terms of your initiating labs and, you know, repeat it as needed as you're bringing them back. But you can easily have a televisit for, you know, the conversation part of the visit and then have them come back for the lab tests. You know, how much do I need to do a physical exam? Not necessarily, you know, I think that we can have them come in, you know, less frequently in person if that is a barrier for them. And do everything else according to kind of what works for them. You know, if there's a local lab they can go to, or if they can just come in for a lab draw. Can you, and then I think the last question is, can you speak about using doxycycline with PrEP? Some patients want to take doxy daily. So I think this is asking about, and correct me if I'm wrong, like doxy PrEP. And doxy PrEP is starting to emerge now as a preventive way of preventing other STIs. However, it's not well, we don't have full data as to, you know, and how well this works for adolescents and those under 18. Last I checked, the data that is out there is really looking at those over 18. And it, again, with adolescents, I think we just need to understand it better and always understand how this relates to, you know, to their behaviors and their ability to plan, you know, around prevention. Any other thoughts or questions?
I just actually attended a lecture about this today. I think it's really exciting that, you know, people who, for one reason or another, aren't as consistent with condom use or like are concerned about chlamydia. I think it's a very exciting prospect. But like Dina mentioned, I think there's a lot of unknowns still about it, especially in regards to potentially conferring resistance. I think especially for gonorrhea, I think doxy PrEP has been studied to mainly have great success in combating chlamydia. But I don't know, I think there could be a lot to grow in this field and to expand PrEP as a whole for other STIs, but I think a lot to still learn.
Yeah, and even doxy PrEP is not meant to be taken like daily indefinitely the way PrEP is, at least like on a regular basis. With doxy PrEP, when it has been studied, it's been mostly around sexual activity and planned sexual activity. So, in the studies that they have seen it to shown some efficacy, it's one in adult populations and tends to work well, like, in settings of high risk sexual behavior. For example, somebody's planning to go on a trip and they know they're going to be having sex during that time, and perhaps with unknown partners or partners of unknown status. So this is where it's kind of currently being considered and practically used. But I think we still need more data to better understand its utility, its efficacy, its potential for resistance, and how to best approach its use with adolescents.
I just wanted to address also the question about referring to us for confidential care. Our group, we the fellows are within the NYP ACN system up in Washington Heights. Our clinic accepts patients with Medicaid, and then our group is also, our attendings are also in the Columbia Doctors Group, Adolescent Medicine, at a couple of different locations where they see both patients with commercial insurance and with Medicaid. And we do have confidential systems in place within our EMR, but of course the insurance and pharmacy considerations would be the same as at your clinic. But we're also happy to come talk anytime, do teaching, but also take referrals as well.
Okay, that was amazing. Thank you so much, guys. It was very much appreciated. We really did have a lot of very interesting questions, which you guys handled amazing. Again, I'd like to thank you all for presenting this evening. It was a nice team. Thank you, Dr. Romo, for setting up this team. Okay, and we hope to have you back sometime next year for follow-up and see how we're doing. We come to a close. I'd like to thank you all for participating this evening. I want to remind the attendees to be sure to complete your post lecture questionnaire so you get your CME credit. I guess before we completely end for this evening and for this year's educational component, I'd like to one more time thank Dr. Romo and her team for this wonderful presentation this evening. We're out on the island, and a lot of commercial insurers. Confidentiality is a major problem, and I think that's a good reason why a lot of the kids they don't really tell you everything. Yeah, and it's tough. You have to feel them out. Again, thank you all. Good evening, and hope to see you soon. Good night.